I'm Paula O'Donnell. I'm the nurse consultant for the practice. So in the practice, obviously, we are not like an ordinary GP practice. We have an open plan office and we go out to visit everybody because we just cover care homes in Salford. So a large majority of our patients have got dementia, so obviously we rely a lot upon the information that we gain from the staff that are looking after them and the families here. So we're relying upon the information that we get from the hospital system, from the previous GP, and trying to get sort of muddle through that information sometimes to when we're new to try and realise what the past medical history is, and that's quite a big part of our role really. And it can take a lot of time, so obviously if I go and see somebody in for example, a new patient, I can give you one example that I'm looking at the moment. She's been, a lot of the time they've been to a lot of different services before they come to us, and they're new. So the preceding 6 months she might have been in 3 different organisations before she comes to us, and there's confusion about a drug, so we're trying to identify what drug she should be on and why they were stopped. And so then I would need to trawl through. We haven't got the information, we have to sort of make a best interest decision and make a best calculated decision, because obviously the decisions need to be made in terms of how to treat them, what drugs we should be using, and what are the reasons that they're on those drugs. So sometimes it can be best guess. I mean, it's not ideal. It sounds great, it just depends how it works really, because obviously we've already got access to the EPR system, we've got access to the SIR record, we don't have any access whatsoever to mental health records, so that would be useful. So I think if the information was available and it was shared in terms of advanced care planning, do not resuscitate, and obviously that outlines the ceiling of care if it's done properly and completed correctly. The paramedics, if they were called out, would know that they're not for admission and be able to see that information. They might not even attend. I mean, most patients obviously who are frail, elderly and have got dementia, if they've not got dementia, often even if they're frail and elderly and have got rheumatoid arthritis and they're very frail, just being moved in a bed, they're really uncomfortable. Putting them on a stretcher, taking them to hospital and having all those distressing questions asked over and over again is not good in their best interest when they've made those decisions. And they don't want to be asked those questions, but also they don't want to be taken to hospital either. And sometimes those things happen and they shouldn't be happening.